Okay, good afternoon, everybody, and thanks for coming today. We have Dr. Hamparian with us, and I will let her introduce herself.
Hi, good afternoon, everyone. It's really wonderful to see this many people interested and joining. So I'm Dr. Hamparian, and I'm a general ophthalmologist. I have my subspecialty in glaucoma, so I do a lot of glaucoma, although we pretty much cover, everything with respect to the eyes, and we'll go over everything. Obviously, my plan is to talk about the most common things. So I'll touch base on the most frequently seen issues, concerns, treatments, and then in the Q&A, obviously we can talk about everything else, or we can go in more detail. So we'll get started here. So the very first thing we will talk about is we'll start off with cataracts. Why? Because it's the most common thing we see. I tell patients, cataracts, we're all going to get it. The question is when. So when we do have it, when we're symptomatic, then we can talk about treatment. The wonderful thing is that treatments are so good. There's so many wonderful different options we can do now that I don't consider it as a disease per se. I just call it just one of these things that happen, and then it's pretty much reversible. So let's go a little bit in depth as to what cataract is. So cataract is a clouding of the natural lens. We're all born with a lens that's crystal clear. It helps us focus. And as we age, it's going to get cloudy. I tell people, it's like gray hair and wrinkles. We're all going to get it. Question is when. So it's not really avoidable. If we live long enough, we're going to get cataracts. So most people end up being symptomatic, meaning it's causing some blurred vision to the point where the patient notices that it's difficult. It starts with difficulty driving at night. Lights might give you glare. So there are a few different types of cataracts that can give slightly different symptoms. Now, obviously, on exam, we can see that the lens has gotten cloudy, and we can tell when it's become symptomatic, and obviously the patient will notice as well. The other thing that's very common is that at different levels of vision, some people are complaining or having more difficulty than others. And why is that? Well, because it happens so slowly, that most people find a way to adapt to that condition. They slowly, will avoid driving at night, or they'll avoid going to, terribly far places or unfamiliar places. So we tend to adapt to our new normal. The good news is, when the cataract's out, everything's back to the usual baseline. So that is something that truly is completely reversible. So it's really good, safe surgery, wonderful results. All the new things that we can do, it's pretty amazing. So let's say it's bad enough to talk about treatment. The treatment's going to be surgical because it's inside your eye. You can't fix it with glasses from the outside. You got to go in, take that cloud out, and replace the lens because that lens has a function. It focuses light. So if you don't replace it, then the eye is lacking. It's lacking something. I tell people it's kind of like when you have knee replacement surgery, right? You take the knee out, you got to put something else in because that knee has a function. So you really need to replace the function of that lens. And the way we do that is implants. Now, there's always advancements in cataract surgery. Probably if there's one thing I can depend on something new happening is definitely in cataract surgery. Why? Probably because, because so many people, get this, that any little improvement will definitely benefit a lot of people. So there's always this drive to do what we do better and better and better. So we said we're going to do surgery and replace the function. So that requires an implant, a lens, an artificial lens. So the cool thing now is that we have all these different options of implants. So we can have the patient see clearly at distance. The patient has astigmatism. We have astigmatism correcting implants. And we also have lenses that focus for you. So if we use these multifocal lenses, then the patient can see at distance, at computer, at reading, all without needing glasses. So it's some really cool technology. It's been around for maybe about 10 years, but they've gotten better and better and better. And really the latest generation lenses do a great job of really allowing the eye to see great in multiple distances. So now these are considered upgrades, and the insurances will cover a standard lens, a basic lens, not these upgradable lenses. The thing is, we have it, we use them. So that's something that on an individual level, a patient can decide if they want to do that or not. But I will say I use these lenses a lot. It's very cool what they can do. So basically, there's a lot that we can do with these technologies. So the first question is, okay, are things bad enough to require surgery? And if we're going to talk about surgery, that's the time to go over these implants, because once we put that in the eye, it's going to stay there for life. So we want to make sure we discuss it, that patients are aware of all the different options. And then once it's in the eye, you can't really go back and change it. So it solidifies into place, and we really don't want to mess with it. So it's, before surgery, this is when you kind of have to decide which way you want to go. So, and then once the cloud is out, the vision really is, restored to, so you really can maximize what the potential of that eye is. Now, what I mean by that is that an eye can have, multiple diseases, and we would know this before surgery. So an eye can have, cataracts and glaucoma and macular degeneration. So when I say we maximize the potential of the eye, because if the eye has other things, it may not be able to see very well. But if it's only cataract, that eye should be able to see perfect. Okay. So I'm happy to discuss some more maybe in the Q&A as far as, surgery and lenses and so on and so forth. But, cataracts, great surgery, very safe, simple, straightforward. It's surgery, but the results are really typically very, very good. So the next thing I want to discuss is glaucoma. So glaucoma is a real disease, okay? That actually harms the eye. It causes damage to the eye. So that I would consider a disease. It's a problem. Fortunately, we have treatments. We have lots of different treatments. So what is glaucoma? Glaucoma is a eye pressure problem. Just like we can have blood pressure that's too high, causing issues. If the eye pressure is high, it can cause damage to the optic nerve, to the eye nerve. Now, early on, we call it the silent disease because it really doesn't give you symptoms, kind of like high blood pressure, right? And people don't know that the pressure is high unless you measure it. So same thing with eye pressure with glaucoma. So it's really caught on exam. And not only would we see pressure, the eye pressure being high, but we can actually, if the eye has damage, that's when we would officially diagnose the eye with this disease, because this pressure is causing a problem. Then that patient has glaucoma, and then we want to treat it. So there's all kinds of different treatments. Fortunately, that's also one thing. In the last several years, we've had some significant advancements in glaucoma, and that's been really exciting, actually, to treat glaucoma, because there's definitely a lot we can do there as well. The key there is you really want to catch that in a timely manner, because if you find out too late, we'll still treat it, right? We're always going to treat disease. However, it's had a chance to cause a lot of damage, and we can't bring back damage. We can keep what's there. And that's when it's really critical. You catch something, you catch glaucoma, early disease, I kind of think of that as a really good thing. That's great news. You found out about a problem that you're going to fix, and it's not going to get a chance to cause progression. And if you catch it late, then you already have all this damage, all this disease. And again, we'll treat it, but we can't replace what's damaged. So it's important to catch glaucoma early. So I said there's lots of new exciting treatments. Well, we've always had drops. So it's simple enough. We've had some new categories of drug in the last few years, which is always good to have more and more options. We also have, ways to treat it with the laser. Bottom line is, whatever we do, we want to decrease the eye pressure, and that tends to control the disease. So we've also had surgery. We've always had glaucoma surgery. However, we have this newer method of surgery, which is really much safer and predictable and with much better results, called canaloplasty. So the issue with glaucoma is that if the pressure is high, the eye has fluid production and fluid drainage. So if you clog up the drain, that's going to push up the pressure in the eye. So theoretically, if you clean out that drain, that pressure will come down and you will be able to control the disease. So we have this much safer surgical way of cleaning this the canal. And that's basically what I'm talking about, that this newer way where it is, excuse me, one second. This canaloplasty surgery, where we clean the drain, the vision recovers very quickly. The pressure typically comes down. We're able to get about 80%, 90% improvement in pressure, which is in a very safe way. That's very exciting for glaucoma. And I would say the most frequent time that we do this canaloplasty is we combine it with actually cataract surgery. Why? Because if a patient is on drops and they're doing fine, that's great. But if they're gonna have cataract surgery, we're already in the eye. We're in that vicinity. We're in that area. We're right next to that real estate. So I always will address the glaucoma as well by cleaning out the drain at the same time. Now, of course, I do this individually as well. But if someone is doing, if they're controlled on drops and they're doing fine, there's no real, or if someone wants to get off drops, we can do this procedure. But I would say the most frequent time when I end up doing that is, it's an easy time to combine it with cataract surgery. Because with one surgery, we take care of both at the same time. So otherwise, again, drops, they've been around for a long time. but yeah, we just have more and more options. Lasers, it's the same laser. Surgical is this canaloplasty that's actually really has been very exciting. It's called MIGS surgery or micro-incisional glaucoma surgery. And that's been the biggest, exciting and newer thing in glaucoma surgery in the last several years. So that takes care of glaucoma. Next, I want to talk about dry eye. So I quantify dry eye as the most benign, right? Nobody's going blind from dry eye. However, it's probably the most annoying disease that somebody could have. Why? Because you feel it acutely at every moment, every day. Patients are having dry eye symptoms. So even though it's not the worst thing in the world, it's really the most annoying and frankly the most common complaint I get on a daily basis is going to be dry eye related symptoms. And so women, as we get older, hormonal changes, women definitely have a higher propensity of having dry eye. Although obviously, men are not immune, especially smokers, because the smoking will actually, throw off everything, including the tear film and the tear layer. So I see more dry eye in men who are smokers rather than non-smokers. So, okay, so what do we do for dry eye? Nothing too exciting there. We've had drops, artificial tears to soothe it. We always start with tears. Next, there's prescription medications. There's pretty much two classes of drug, and they've been around for a little while now, and they're safe, they're good. It's a trial and error thing. You've got to do that. There's also plugs we can use to clog up the drain. So whatever tears the patient has, their own tears will keep the eye, comfortable. We also a lot of times will address the eyelids because a lot of causes of dry eyes from eyelids being having blepharitis or just inflammation, so on and so forth. In addition, if someone has a skin condition like eczema or psoriasis or whatever, that inflammation right around the skin, even if it's here, will affect the eyes. So that definitely will be a contributor to dry eye. So it's a little bit more holistic. You really need to address all those things to try to make sure that the dry eye is getting treated appropriately. Next, I wanted to talk about the next most common thing would be macular degeneration. And again, macular degeneration, I would consider that as a disease. It's something not everybody gets. Some eyes will get that, and not others. And it's a real, disease where the retina has a problem. And the problem with macular degeneration is that it really affects the center vision. Unlike glaucoma, where the patient may have it early on and may not know there's anything wrong, macular degeneration can affect the center vision. And so most people can really tell if there's a change. Now, I'm sure all of you know somebody who's getting injections in the eye. And that's most of the time it's macular degeneration treatment. It's very common if someone has wet macular degeneration that they're getting injections in the eye. And those things really do a lot of good. It sounds worse than it is. It's actually very simple and it's very quick and it's very safe to do those injections, but they really do a lot of good. There's some really dramatic improvements sometimes we see with these treatments. And the key there is, once again, let's back up a little bit. So macular degeneration, we classify it into two categories. There's dry macular degeneration and wet. So everybody starts off with dry macular degeneration. And at that stage, there's really not that much visual issues. We can see evidence of the disease in the eye when we examine it, but there's really, the vision is still really good, and it really hasn't dropped very much. So when it turns into wet, you can sometimes get a very precipitous drop in vision. And the sooner you start these injections, and those injections are all geared towards wet macular degeneration, the sooner you start, the better outcomes that eye is going to have, because that wet macular degeneration is not going to have a lot of time to cause some really, really serious damage in the retina. So the sooner you start it, and it is pretty frequent injections, they really do a lot of good for the eye. So all of this is basically, you know, a lot of it we want to see the patient in order for us to find all these diseases. So let's talk a little bit about prevention. Well, the recommendation for eye exams is going to be after 60. We typically say we want to see you once a year. Why? Because if there's something there, we want to catch it early. A lot of eye diseases start as we get older. So we're not going to be looking at 20-year-olds, right? I mean, those kids are going to need glasses, things like that. But we don't find cataracts in 20-year-olds, or macular degeneration, or glaucoma, dry eye, right? So a lot of the eye issues really happen as we get older. So we want to see you every year, every other year, 40s and 50s, unless there's family history of, diseases that we want to start screening early. At the very least, after 60, really want to see you once a year, because these things, like I say, happen as we get older. So a lot of it really is prevention. If the eye has glaucoma, we want to find that early and start treatment so it doesn't have a chance to cause further damage. Cataracts, like I say, the patient's going to notice something's not right. So a lot of times they'll come in because they've noticed, I just don't see as well. But it could also be macular degeneration, or it could be, corneal issues. So, it's best to, catch these things, do some prevention. For macular degeneration, we have some, vitamins we recommend. If someone is a smoker, we want to tell them, please stop. Also, if someone is prone to macular degeneration, we know that uncontrolled high blood pressure and cholesterol and diabetes, those things tend to make the disease worse. So when we want to see you once a year to catch things early and talk about treatment. But I would say besides that, what would be helpful? How can someone take care of the eyes as far as things that patients can do, and prevention, and so on and so forth? Well, I've noticed over the years, right? I have these, 60-year-olds who have, poorly controlled blood pressure and cholesterol, and they really don't take care of themselves, and they're a smoker and and the eyes don't look so great either at that age. They already have problems in the retina from the high blood pressure, plus the cataracts are bad. They're going to need surgery earlier. And then I have these other patients who are in their 80s and 90s, and their eyes look really good. Now, some of it's genetics, but a lot of it is really in our hands. So those patients who are making it to those, 80s and 90s, and they still don't need cataract surgery, It's because I find that, they take care of their body, they take care of themselves, they exercise, they eat well, and if they have high blood pressure, they control it. If they're, cholesterol, diabetes, all these things, the body's in good shape. And also more and more we're finding, if the patient has a lot of excess weight, that is the cause of all these issues. So people who are, can exercise automatically, right? They're not going to have issues with weight for such as diabetes and blood pressure and so on and so forth. So I tell patients, if you want to take care of your eyes, if you take care of your body, your eyes are part of it, and you're going to actually help your eyes just as much as the rest of you. So I think it really is a good idea to take care of all those things. It's actually simpler to do than, be on all these medications or, surgery and da-da-da. I mean, it's a good thing we there's a lot we can do, but I think we all know prevention is always simpler, easier, and better than having to treat with 20,000 medications. So I tell people, hey, take care of yourself, and the rest just happens. I don't know if I touched base on diet. So vegetables, like just healthy vegetables, antioxidants, these are those are very good for the body, for cardiovascular, as well as cataract prevention, because there's a lot of antioxidants in the body. Then the body can heal itself, and it just does not age as quickly. I wanted to touch base on one other problem, which is diabetes. We didn't talk about diabetes. You probably all know diabetics, it can affect the eye too. And if the diabetes has not been in control for a long time, and I mean years, it can start to affect the eyes, and it can affect the retina, and the vision starts to go down because you can get some fluid leakage into the retina. And that's the other scenario where patients get injections. So fortunately, we have treatments for that. It's laser, injections, so on and so forth. However, especially in the case of diabetes, it's a lot easier to prevent it all by controlling the blood sugar, so you never get to that stage. So the reason why I mentioned it is because a lot of the patients that are getting injections are also diabetics. So it's that same injection that will help diabetics as well. So honestly, these were the most common eye issues that we see. So I wanted to make sure we hit on those. And then I think we can certainly open it up to Q&A, so we can discuss further in detail if anybody would like.
Okay, thank you. Let me stop the recording.
Okay.